So we're going to, as we said, we're going to move a little bit further down, and we're going to talk about chest. And this is specifically for non-mammographers, so we'll won't be touching or talking much about breast. Okay, so for many of our practices, we have an exam code that's called something like this. Our institution is called ultrasound of the chest/mediastinum, maybe called ultrasound chest wall, chest non-breast, and this bucket encompasses a large number of body parts, a lot of which we don't typically image with ultrasound, which can leave us a little bit confused at times. So in this segment, we're going to talk about how chest ultrasound can be helpful to guide clinical management. We'll discuss some of the chest wall anatomy as we see on ultrasound, and we'll explore some of the many diagnoses and conditions of the chest, taking an approach from the outside in, so we'll talk about chest wall, touch very, very lightly on breast, and move on to some of the intrathoracic contents. So why would anyone do a chest ultrasound? As I alluded to before, a lot of the chest imaging, especially when looking for bones or lung parenchyma, is done with radiographs and CT. And so ultrasound is not our primary imaging modality. It is frequently employed by our emergency department colleagues, however, because it can be rapidly done at the bedside. You don't have to move the patient. In addition to that, some of the additional advantages include the ability to do a real-time or dynamic evaluation, and this is really helpful for musculoskeletal etiologies. Chest wall pathology can actually be quite superficial, so using our high-resolution linear transducers can be really helpful in this setting. And in addition, when compared to CT, it has a relatively lower cost. So just a basic review of chest wall anatomy, as you can see on ultrasound. So here's an example of a transverse image of the chest wall, which was obtained with a linear transducer. So the first or superficial most layer is the skin, which is a little bit iso to a slightly hyperechoic layer. And just beneath that, you have the subcutaneous fat, which appears relatively hypoechoic with its characteristic undulating or wavy hyperechoic strands. And beneath that, there's a layer of muscle. In this case, we're imaging probably the intercostal muscles in a longitudinal plane, and again, characterized by its signature look of hypoechoic with linear strands. So the ribs, you can actually see pretty well on ultrasound. They cause posterior acoustic shadowing and have a bright linear acoustic interface, and that corresponds to the anterior cortex. And the costal cartilage is just adjacent to that, also hypoechoic, but unlike the ribs, you can actually make out the posterior border of the costal cartilage. So depending on where you're imaging in the chest wall or along the chest wall, you may encounter very different orientation and different groups of muscles. So for example, if you're in the anterior upper chest, then you would expect to encounter some of the pectoralis muscles, maybe some of the serratus anterior muscles. And conversely, if you're imaging from the back, there may be some additional muscles like the lats. And in between all the ribs, there is a layer or layers of external and internal intercostal muscles that we should see. So as with any ultrasound, the technique should be modified or just specific to the case at hand. So for chest wall pathology in particular, the structures tend to be very superficial. So we frequently image high-frequency linear transducers, and we're looking to evaluate structures that are deeper in the chest, maybe in the intrathoracic cavities, and we may elect to use a curved transducer. Panoramic imaging comes in really handy for the chest wall pathology because a lot of the structures are superficial but quite elongated, like, for example, ribs. And then comparison with the other side can be oftentimes the key to many of the diagnoses, and hopefully your other or asymptomatic side is normal. And to do the dynamic evaluations for your musculoskeletal etiologies, we may have to employ some creative repositioning of the patient and some maneuvers to reproduce the patient's pain. So now we'll move on to some of the example cases. Again, we're going to approach this from the outside in, and we'll peel layer by layer. So the first area I wanted to tackle was skin and subcutaneous tissues. I think we see this a lot. I'm going to talk about epidermal inclusion cysts. So the definition of this is proliferation of epidermal cells. It can be within the dermis, hypodermis, subcutaneous tissues. And it's a circumscribed area of proliferation. And more than 90% of these happen within the upper body, including the scalp, face, neck, trunk, and back. So the optimal management of this is surgical excision. So when they become excised, you find this nicely encapsulated ball of keratin. You can elect to drain them, but that's not the ideal approach because they tend to recur. And histopathologically, they are lined by squamous epithelium and filled with keratinous debris inside. So here's a classic example of an epidermal inclusion cyst on ultrasound. As we alluded to before, these are circumscribed masses with well-defined borders. They can look very solid or complex and are composed of variable echogenicities. Even though the diagnosis itself has the word cyst in it, it's not always associated with through transmission, and in some complicated cases, they may be ruptured. Okay. Going to touch very lightly on breast. So in our institution, the ultrasound service provides the imaging for rule out breast abscess. And this always gives me a lot of anxiety because I'm always thinking, what if it's not an abscess, and are they going to ask me to drain this? So we'll talk a little bit about it. So breast abscesses happen frequently in young women, especially those who are lactating. If it is a patient who is not lactating or breastfeeding, then it may be associated with some other risk factors, such as obesity, tobacco use, and some other inflammatory conditions such as diabetes or rheumatoid arthritis. Clinically, the patients present with localized pain, redness, and heat. And actually, the systemic signs such as fever can actually be rare in these cases. So on imaging, the typical imaging appearance is of a hypoechoic collection. If it has a lot of fluid within it, then it may be associated with through transmission. And unlike abscesses elsewhere in the body, they may not always have this thick rim. So if it does have it, then it tends to be a little bit echogenic and very vascular. So here's a classic example of a breast abscess. This is a hypoechoic collection with through transmission, and it actually has a well-defined hyperechoic rim. And in this case, this was aspirated and it yielded pus. This is a different example of a breast abscess, but it's a little bit harder to make out than the first example, and part of it is because it's so isoechoic to the adjacent soft tissues. As you can see, there's not that much hypoechoic fluid component in here, so in this case, aspiration was attempted, but it was not very successful. So here's an example. This was one of our cases. It is a patient who was 4 months postpartum. She is breastfeeding, had recurrent episodes of mastitis. So she came to our department for imaging evaluation. And our imaging reveals a hypoechoic kind of heterogeneous area within the breast tissue. Not really that much drainable fluid component. So this is a phlegmon or early abscess with little drainable fluid component. Here's a slightly different clinical picture. This is a post-op breast. So this patient had undergone bilateral mastectomy with tissue expanders placed, found to have redness and pain at the site. And when we image it, there is a large peri-transplant collection. It looks heterogeneous and complex with isoechoic debris and numerous septations. And again, unfortunately, with very little drainable fluid component. So the management of breast abscess tends to be a little bit of a stepwise approach. So the first line is with antibiotics. And then if that doesn't help, then we can attempt aspiration. And for these, I think it's recommended that we consider a follow-up ultrasound in at least 7 to 14 days to make sure it resolves. And if all these measures fail, then surgery will have to be considered. Just for comparison, I put in a picture of inflammation here. This is technically a post-mastectomy patient, so I guess it's not really mastitis, but you can see that there is a large area of heterogeneous soft tissues overlying the pectoralis muscles, and the color Doppler interrogation reveals internal flow, and again, there's no drainable fluid component. Okay, moving away from the breast now, we're going to talk about hematoma. So this is a chest wall hematoma. This patient actually had recently undergone an AICD placement, so I'll let the cine loop around. But I think it's kind of cool because you can see the battery pack insertion site with leads emanating from the battery pack. And we'll let it play one more time. And just adjacent to the battery pack, you see this complex fluid collection. It has echogenic debris, septations. So this was consistent with a hematoma. And this was a corresponding chest CT. So you can again see part of the battery pack and a hypoechoic fluid collection just adjacent to it. But it's really hard to appreciate the complex nature of this fluid collection just based on the CT hypodense appearance alone. So this is where the superior spatial resolution of ultrasound can come in really helpful for the clinicians. Okay, another entity that we need to talk about is chest wall abscess. So this is an example of empyema necessitans and a subpectoral abscess. So in this transverse image, you can see hyperechoic debris kind of extending from the intrathoracic area into the just underneath the pectoralis muscle layers. And here, there is a beautiful panoramic image, again showing you that this hyperechoic debris comes from within the chest wall cavity, and it extends in and kind of interleaves itself between the layers of the pectoralis muscle. So beautiful example of how we can employ panoramic imaging here. Moving on to more infection cases, we can also see osteomyelitis and septic arthritis. So this was a patient who presented complaining of chest wall pain, and in the area, that area corresponds to the sternoclavicular joint. So we see hypoechoic material situated within the sternoclavicular joint. There's breakdown of the cortex, bony cortex that you can see at this joint, as well as a small component of fluid. So this is osteomyelitis or septic arthritis. And when you interrogate with color Doppler, the whole area is hyperemic. So again, consistent with infection. Slightly deeper into the chest, we can even see mediastinal abscess with ultrasound. This was a case of a 7-year-old boy. He presented with kind of a viral prodrome. He had fever, myalgia, and he was admitted, and the workup revealed that he had some bacteremia and septic emboli. So then this happened to be a chest ultrasound that we did, and I think it's a little better if I show you what the structures are. So there's a heart. That's actually the left ventricle. And then adjacent to it, you can see dirty acoustic shadowing from the lung parenchyma. And on top of that is this complex hypoechoic collection. So that's the mediastinal abscess. And I'll show you the corresponding CT, again, showing you that same exact picture, hypodense collection right in front of the left ventricle, just corresponding really nicely with our ultrasound image. So again, the ultrasound really helps identify the complex nature of the abscess here. Ultrasound is not limited to soft tissue structures. We can actually look at bones and cartilage as well. So rib fractures. I don't know, this probably happened to a lot of us sitting here, but I have been surprised many times when I look at chest x-ray and I'm like, oh, it's normal. And then I look at the chest CT and there are all these non-displaced rib fractures that I missed on the chest x-ray. So chest radiograph is not so great for non-displaced rib fractures. We can actually frequently miss them. And it can be actually easier to diagnose rib fractures on ultrasound with pretty high sensitivity. And part of this is because the patient can tell us where the pain is. So this was a patient who complained of, who reported rib trauma about 3 months ago. This was the image we got on the targeted ultrasound. You could see a tiny break in the anterior cortex of the rib, and this is kind of anterior rib closer to the costochondral junction. And I'll show you the corresponding chest x-ray. So this was the initial chest x-ray, which was ordered first. And even if you zoom in really closely to the area of pain, which was the right anterior lower rib, it's very hard to see. And he actually ended up getting a rib series as well. And I think this time it's a little bit easier, and there's a BB marker to help us. And there's a tiny non-displaced fracture right at the tip of that rib. Again, ultrasound kind of helped us out in this case. This is another patient with a rib fracture. This patient actually presented for liver transplant imaging, and while we were imaging the chest, the patient complained of focal tenderness. in the right upper quadrant. So this is when we took out our linear transducer and looked at the chest wall, and there is a tiny, minimally, maybe non-displaced fracture of the anterior cortex here. We're going to move on to costochondral pain. I think this was a 17-year-old male. He was a young patient who presented with focal tenderness. We'll again see a BB marker denoting his site of pain, which is the right anterior lower chest. The chest radiograph was not very revealing. So he came to us for ultrasound, and when we put down the probe, there is some muscular edema and minimal hyperemia in the area of his pain, especially when you compare it to the other, hopefully normal, left side. And when we interrogate this further, his area of pain corresponds to the costochondral junction on the right side, and this is Dr. Tara Morgan's images, so it has her initials on it. But you can see that the whole area on the right side is asymmetrically enlarged compared to the left, and his site of pain actually corresponds exactly to this point. So in this patient who has all these reactive signs and focal tenderness, this is pretty suggestive of costochondritis. Okay, we're going to talk about more musculoskeletal etiology. So I'm going to talk about slipping rib syndrome. It has an eponym. It's also called celiac syndrome. This happens frequently in younger patients, so maybe more encountered in the peds or young adult population. So the theory behind this is that ribs 1 through 7 are firmly attached to the sternum. However, the lower ribs 8 through 10 kind of hang loose, and they're attached by weaker fibrous tissue. And so even minor trauma at this area can result in abnormal motion. And this positional subluxation is felt to impinge the nerves and be quite painful for the patient. So here is a patient who presented with those kind of symptoms, and I'll show you the normal side first. So we're imaging in a parasagittal approach, kind of where you would expect the costochondral junction to be. And this is in the sagittal view. Okay, so this is a normal side. We're imaging at levels, I think, 9 and 10, or 8 and 9. So the normal side, when the patient is performing her dynamic maneuvers to reproduce the pain, you can see that both ribs are firmly attached and they're moving together. So I'll let that stop playing. Okay, stop playing. Just kidding. Okay. And then compared to that to the abnormal side. So the lower rib is actually slipping in front or anterior to the higher rib. You can almost hear the click in your head, I think. Moving on. Okay, so that's one example, and here's a better example that, again, Dr. Morgan showed to me. So this is another patient. This patient came in with left lower anterior rib pain. And you can see there's a small, tiny rib. The inferior-most rib is slightly hypoplastic in this case, but it's actually moving slightly, clicking backwards first, and then clicking anterior again, and then again reproducing the patient's pain. So this is slipping rib syndrome. Okay, in the last few minutes, I'm going to talk more intrathoracic cavity. So I'm going to talk about diaphragm paralysis. So when we think of this indication, we think of a fluoroscopic sniff test, but you can also do this with ultrasound. So diaphragmatic paralysis is defined as absent excursion on breathing and is associated with paradoxical motion and stiff. Weakness is reduced or delayed excursion, and they may or may not be associated with this paradoxical motion. And it's, the etiology is phrenic nerve injury, which most oftentimes is from cardiac surgery, but it can also be from tumor, radiation, or infection, inflammation at the area. So ultrasound has some advantages over fluoro. So ultrasound is portable and it has no ionizing radiation, so it might be really helpful for pediatric patients. So how to do this? We look at the liver diaphragm or spleen diaphragm interface on ultrasound, which I think we all know is a bright echogenic line on imaging. And this can be done in the transverse plane or longitudinal plane utilizing intercostal or subcostal windows. And we basically observe the diaphragmatic excursion on B-mode imaging. And when we employ M-mode, we can actually quantify the amplitude of diaphragmatic excursion as well. So here's an example of a normal patient. So again, we're imaging this bright echogenic interface between the liver and the lung, corresponding to the diaphragm. And you can see that it's moving well with the patient breathing. And then this is with the patient sniffing. A little bit more sudden movement, but you can clearly appreciate that the diaphragm is moving adequately. And so when we employ M mode, you can actually look at the pattern of movement. So the diaphragm should always be moving closer to the transducer probe. So the inspiration should correspond to this uptick, again with sniff as well. And here are more examples in a normal patient. So this is the patient at quiet respiration. This is with deep breathing. And this is with sniff. You can actually see the sniffs. And so here's an example of abnormal. This patient had undergone bilateral lung transplants as well as the right lung decortication. And so we imaged the right side first. It looks a little bit different from the examples I showed you. It has very little excursion. And we'll compare that to the left side. So clearly different right versus left. So in this patient, she has right diaphragmatic weakness. Okay, pleural space is also an area where ultrasound can be helpful. So ultrasound is sensitive for identifying even the smallest of effusions, and we can assess for internal complexity of the fluid. So this is an example. This patient, obviously complicated post-operative patient. You can see a small sliver of fluid in the right costophrenic angle. And conversely, on this radiograph, I think the angles are pretty sharp here, and you would never call it infusion here. So ultrasound can detect small effusions, even as low as 20 cc's compared to 100 or 150 cc's for radiographs. And pleural effusions come in different flavors. So it can be simple, totally anechoic. It can be simple and combined with atelectasis. This is the atelectatic lung that's floating around in the effusion. Or it can be complex, as you can see here. And then another indication is for empyema. So this is a pediatric patient who presented with pneumonia, and if I read this chest radiograph, I would say there is a large effusion and left lower lung disease. When we employ ultrasound, I think it's really striking that you could see all these complex septations within the pleural space, and you can actually see the pneumonia on ultrasound. So this is called hepatization because it kind of looks like a liver with air bronchograms within the consolidation. Just another picture to prove the point. Again, septation and consolidated lung, heterogeneous appearing with air bronchograms here. So I think I highlighted some of the areas where ultrasound can be really helpful for clinical management and where the advantages are. And I think it's a good complement to the other imaging modalities we have. And I wanted to say special thanks to Dr. Tara Morgan for inviting me here and giving me all these cool cases.